Hello, I'm Mike Fasano, founder of Fasano Associates, and I'd like to welcome everyone to what is the second of our quarterly series of webinars. Today we'll be discussing falls, frailty, and functional status, which we see a lot of in the structured settlement underwriting that we do, but it's also, I think, becoming more relevant in life insurance underwriting as our population ages and continues to age. Presenting today will be Dr. Scott McClure, who is a medical director at Fasano Associates and who also is in clinical practice. Scott got his Bachelor of Science, his MD, and his residency in emergency medicine at the University of Texas. His orientation to internal medicine and emergency medicine, I think, gives him a really good perspective on falls and frailty and functional status. So we're happy to have him as a part of our team. And again, he's been very helpful in the cases that we've reviewed. So without further background, I'd like to turn it over now to Dr. Scott McClure. Scott?
Yeah, thanks, Mike. As he said, my name's Scott McClure. I am an emergency medicine physician. I've been with Mike here at Fasano Associates now almost going on 4 years. So, Mike, thank you for the gainful employment for the past 4 years. I guess we can probably hold up for maybe 10, 15 more seconds just to let any stragglers in that want to get in. As you can see at the top of your screens, there should be a question box, and if you guys want to type your questions and send them in at the end of the lecture, I'll check those and hopefully get through as many of them as I can. But here in about, I don't know, 10, 15 seconds, we can go ahead and get started. I'm based out of Missouri. I'm originally from Texas, so if my accent sounds a little southern to you, that's probably why, and I apologize. That's probably been about 10, 15 seconds. Let's go ahead and get started. So first and foremost, in regards to this lecture, there's going to be a bunch of Seinfeld jokes throughout. I'm a huge Seinfeld fan. Those of you who are as well are going to enjoy it. If you tend to hate Seinfeld, all I can say is I'm sorry. But the objectives of this is basically I want you to understand the mortality implications associated with falls, frailty, and functional status. I want you to understand how the three conditions are interrelated, because really they're, almost three different aspects of the same thing. And we'll get into that. I want you to understand the mechanisms by which, basically how we define them and stratify them. And I want you to understand the implications of these in both underwriting and what we do at Fasano with more of the life settlement or structured settlement side. Next slide, please. You know, when you're doing a PowerPoint presentation, I was looking for how I got on the Seinfeld kick is Kramer falls all the time. So that's how this whole Seinfeld and this thing actually started. Next slide, please. So how do we define a fall? So the World Health Organization defines a fall as an event where a person goes to rest inadvertently on the ground or other lower level. Now the key takeaway from this definition is inadvertent, right? So if you've got a football player diving for a football, he's going to hit the ground, but that's not a fall. He dove for the football on purpose. If he's tackled and knocked to the ground, well, that's a fall. It's inadvertent. Similarly, if you're diving into a pool, not a fall, but if you slip off the diving board and fall into a pool, well, that was inadvertent. Next slide, please. So how prevalent are falls? CDC estimates about 36 million of these in the elderly every year, and it's probably grossly underreported because those that get up and don't have any kind of injury are not going to present for any kind of treatment, and so we're not going to actually get accurate numbers on how often people are falling. An estimated $50 billion is spent on medical care related to falls in the elderly annually here in the U.S. It is estimated that about 60% of people that fell in the past year are going to have another fall in subsequent years. And about 5 to 10% of those falls result in major injuries, including long bone fractures, hip fractures, intracranial hemorrhages, or major lacerations. you probably, one thing to take away, 50 billion is a lot of money, especially in U.S. healthcare. And the reason that it can be so expensive is, at least in my background in emergency medicine, when you have people that fall, specifically in the elderly, sometimes they can be poor historians, and they are prone to serious injuries. And they basically get a very expensive workup, including CAT scans of the brain, basically through the neck, the chest, all the way through the abdomen, pelvis, plus any kind of possible bruising, and long bone x-rays we have to look at for fractures. We actually call those trauma scans, but they're expensive. And so that's just the initial workup to look for injuries, not even putting together if we find them and the admission to the hospital and all those costs that come with that. Next slide, please. So why do we care? What's the morbidity with this? So fall-related injuries are associated with significant morbidity and changes in functional status, and may even be the precursor to somebody needing to go into a nursing home. Complications resulting from falls are actually the leading cause of death from injury in individuals over 65. So not leading cause of death, but death from injury. Whereas someone my age, leading cause of death from injury is going to be a car accident. And that's true through your 50s until you get about to 65. And suddenly it's not the car crash that's going to kill you first. It's a fall, unfortunately. And you can think about like the significance of this. Just we'll give you an example. If you've got a 75-year-old lady, she's otherwise healthy, not a lot of medical problems, and she falls, she's less likely to sustain a significant injury, and she goes on. But you have another 75-year-old lady, maybe she's osteoporotic, doesn't get around too well, has a fall and a hip fracture. Well, that hip fracture, which could have a recovery of like 6 months, assuming she survives it, she may need, aids at home, may need to go to a nursing home, all because predicated by this initial fall. Next slide, please. So what are the risk factors? Like, how can I pick out somebody if I'm reviewing medical records that's at risk for falls, hopefully before they've had a major fall? So as I told you before, prior history of fall, right? Somebody that fell last year has got a 60% chance of subsequent years having another fall. As we age, and I'll show you in some charts a little bit later on, but as you age, obviously your risk of fall and the percentage chance of fall goes up each year. Females are much more likely than males to fall. Lower extremity weakness. So if you've got one weak leg and you're off balance, you're obviously more likely to fall. If you're cognitively impaired, you obviously risk for fall, just because if I spilled water on the floor and then forgot I spilled water on the floor, I might slip on the water. Or if I forget there's a chair in my room at night, I might trip over the chair. People with balance difficulties, obviously, you're going to be at risk of falling. Psychotropic drug use, so that tends to be the medications like antidepressants, anti-anxieties, Benadryl, all have these psychotropic effects. The reason that these can increase the chance of falls are basically they can lead to cognitive impairment in the elderly, and they can lead to balance difficulties. So that's one of the reasons that they can cause falls. People with severe arthritis, if they're limping because of pain or swelling in a joint, are obviously going to be at risk of fall. History of stroke, for the same reason of having lower extremity weakness or balanced issues. If you've got any kind of neurologic deficit, you are increase of falling and hitting the ground. Vertigo, I don't know if any of you guys when you were kids would get on, try to spin around real fast and walk a straight line when you're dizzy, but that sensation of the room spinning around you, almost like you've been on a roller coaster, is vertigo. And walking straight is hard when you have vertigo going on. So it increases our fall risk, not just in the elderly, anybody really. Neuropathy. So neuropathy basically means you have numbness and tingling, typically classically in your feet. So you don't really feel things in position. You could be not standing flat, meaning your foot's starting to kind of turn over a little bit and not know it, or you could be standing on something that isn't stable and not know it, leading to a fall. And finally, orthostatic hypotension. So that's basically when you stand up too quick, you get that lightheaded feeling. That is orthostatic hypotension. It's more profound in the elderly population and actually can lead to them passing out and falling. Next slide. So as I told you before, as you increase in age, your fall risk goes up. Now, females are in blue and male are in orange on this chart. I probably would have done it the other way. The thing I want to point to the chart is not only that as we age, your fall risk goes up significantly, but that females are more likely to fall than men. There's an error in this graph, basically between the ages of 75 and 85. It looks like that 10-year period that men are more likely to fall. That's wrong. Across the board, above the age of 65, females are more likely to fall. Next slide. We talked about this a little bit ago, but yeah, not all falls are created equal. When you're evaluating and reviewing records and trying to decide if somebody's going to be accepted for life insurance or someone's going to be declined based on falls, you've got a 65-year-old male who's training for a half marathon and slips on a curb while he's running. It's completely different than somebody that's a poorly controlled diabetic that's had a prior amputation and one leg and gets very dizzy just getting up on her feet. I mean, those fall risks, if they fall, obviously are significantly different when you're trying to view the risk category of those people. A key takeaway is that indoor falls in general are associated with higher degrees of morbidity and mortality than an outdoor fall. The way I like to think about it is if somebody falls outside, that means they were able to get outside. Whether they were exercising, which is obviously awesome, or if they had gone to the store, that means that they're still doing their own shopping, still going to the store. For whatever reason, they were able to leave their house. Indoor falls, I mean, everybody in their house, you're pretty aware of your environment, you get used to it. So if you're having falls indoors in the place that you live every day, it's going to say more about your functional status in general. If I, suddenly I can't get up the stairs anymore without potentially falling back down, that's more significant when you're assessing the risk of that. Falls resulting in long lie. Long lie I like to think of, I don't know if you guys remember from the 1990s, those life alert commercials that were all over the TV, especially daytime TV. I've fallen and I can't get up. That's basically what a long lie is. And it's associated with a significant increase in morbidity and mortality. The reason is it's twofold. One, if you've got somebody that has a very poor functional status and is frail and weak at baseline falls and just can't get up because they're too weak, obviously their pretest probability of having a prolonged hospitalization for physical therapy, rehydration, whatever's going on there is going to be higher than somebody that was able to fall, didn't have an injury and got up. Somebody healthy, say you've got a very robust, 75-year-old without a lot of medical problems falls and now suddenly they can't get up because of an injury, right? They could have had a hip fracture, they could have had a head bleed and were unconscious, all of which leading to this long lie. So whether they're healthy before the fall or they weren't healthy before the fall, if they're down and can't get up without assistance, that's associated with increased morbidity and mortality. The ones that obviously the injuries that we're the most concerned about from a mortality standpoint are the long bone fractures, like a hip fracture, and then obviously intracranial injuries, head bleeds. So this is a Kaplan-Meier curve. This is basically illustrating what we talked about a second ago about indoor versus outdoor falls. And they did this study looking at people that had been hospitalized for hip fractures. So all elderly patients over the age of 65 all had hip fractures. And what they were looking at were, what basically led to the fall that caused the hip fracture. And so your first chart in Group A, they were looking at high versus low risk causes. And the third line in all these graphs is outdoor. And as you can see, outdoor falls, people do the best, lowest change in mortality and morbidity. So Group A, high versus low risk cause would be meaning like, I just lost power in a leg. That'd be a high risk. Low risk would be like, hey, my dog in my house knocked me over, or somebody spilled water I didn't see and I slipped. The second chart basically looks at what the activity you were doing, right? So obviously outdoor we said is the lowest risk. A high risk thing would be like something you'd have to do every day. Like I was trying to sit in a chair to eat my dinner and I just lost power and I fell. Versus, I was trying to do something I don't normally try to do. Like I was up on, standing on a chair trying to clean dust and I lost my balance. Felt a little bit different. And finally, C, it says high versus low risk cause. And basically, it's a conglomerate of the two. They looked at like the cause and like the ultimate, like did you lose power, did you lose balance, that kind of thing. And again, outdoor was much less risky in terms of morbidity and mortality standpoint compared to indoor. So unintentional fall deaths. I've told you guys multiple times now that obviously females fall more likely to fall than males. The caveat though, the weird thing is men who do fall are much more likely to die from a fall. Males have a higher percentage chance of death from a fall. My reasoning, this is I don't have data to support this, but my personal belief is the men that are in this chart that are falling are frail and osteoporotic and have a low functional capacity at baseline are the ones that are falling, and therefore they're taking more significant injuries and dying. Whereas females, ubiquitously have a higher increased fall risk, and so I just don't think the mortality is there in comparison to the men that fall versus the men that don't fall. So, is there different testing we can do as doctors to basically in the office when we're seeing patients assess for who's going to be at risk of falls? So, three that are commonly done are what's called up and go testing, gait speed testing, and the Berg balance scale. Of these three, up and go is by far the most common. We can talk about that on the next slide. So basically, how up and go works is you're sitting in a chair in your doctor's office. They're going to start a timer, and you're going to stand up. You're going to walk 10 feet away from the chair. You're going to turn around, come back, and then sit back down in the chair. If you can do that under 10 seconds, that's considered normal. If you can do it under 20, basically it means you're fairly mobile for your age, and they don't think you should need an aid or a walker. Anything over 30 seconds is considered to be a fall risker. You may need some sort of assistive device. So what's the mortality risk associated with these falls? So Coutinho et al. That study was done in Brazil in like 2012, but it's pretty well cited. They were looking at falls, mortality after hip fractures. So severe fracture, typically, like as I said before, is a hip fracture. But the mortality after a hip fracture in 1 year was predicted to be 25%. Those without a severe fracture was about 4%. Similar study, Roche et al. Saw a 9% 30-day mortality risk after a fall and 33% after 1 year. Again, those falls with a significant injury. So in terms of life underwriting, most of the life underwriting manuals are recommending declines for 3 or more falls in a single year. A single fall resulting in this long lie that we talked about, or a history of like recurrent falls with multiple risk factors, which obviously we just went over. So how can we like prevent it, or you prevent it as we age? Exercise, in my opinion, is the most important. Muscle mass, being regular, diligent with your exercise, is going to help you for multiple reasons. If you've got a good muscle mass, good balanced core, you're obviously less likely to fall. And if you start, the younger you start exercising and keeping your muscle mass up as you age, the less likely you are to develop some of these comorbidities, such as diabetes, neuropathy, things that put you at risk for falls. So of everything, in my opinion, exercise is number one. Beneath that, obviously, like if you have issues with, say, vertigo, or you've had an injury and you're a little weaker, secondary to a previous injury, and say your right knee or something, physical therapy is a good thing to help you with those. Balance training can be helpful. As we talked about, the psychotropic medication, especially in elderly, the less polypharmacy or the longer the medication list we're dealing with, if we can just shorten that down, that's going to help prevent falls. Assisted devices, obviously, somebody who needs a cane or a walker should use a cane or a walker. Somebody that needs a wheelchair should use a wheelchair. And then just patient education, family education, and home safety, meaning, that we have family or people making sure that the houses that our elderly population are living in aren't death traps. There's things in the bathroom to help them get in with bars and seats, so we don't have falls in the bathroom and showers. It's important as well. So this is basically, this slide got taken out of Up to Date, which is a common resource for physicians. It's basically how a doctor would go through and assess fall risk on patients and the kind of stepwise pieces that they would do to address those things. We don't have to dwell on it though. Frailty. I love the Mandelbaums from Seinfeld. That was always one of my favorite episodes. Next slide, please. So frailty is one of those things that I think it's pretty easy to conceptualize, but kind of harder to define, right? Most of you could probably point to a person that looks robust, very in shape, and say they look healthy, and somebody that's very frail appearing, skinny, disheveled, malnourished appearing, very weak, frail appearing, and saying that person looks frail. But the actual definition is essentially that it's a syndrome with multifactorial causes, making individuals more susceptible to adverse outcomes from both internal and external insults. So basically, I like to think of it as comparing someone who's healthy to someone who's frail. And so somebody who is healthy, if they have a fall, ground level fall, are less likely to have a significant injury. That same frail person having the identical mechanism, velocity, forces involved in that fall, more likely to have long bone fractures or intracranial injuries, longer hospitalization. Those are the external insults. Internal insults are going to be like things like infections. So you take that same healthy person, gets a run-of-the-mill urinary tract infection, is likely just going to be treated as an outpatient with oral antibiotics, get better with minimal symptoms. That frail person is way more likely to develop an ascending urinary tract infection, get sepsis, and end up in the hospital for weeks on end. Frailty is often associated with diminishing functional capacity, weight loss, cognitive changes, depression, as well as increased dependence on their caregivers. So how prevalent is frailty? So in nursing homes, it's pretty dang prevalent. It's about 50% of the population living in nursing homes meet criteria to be classified as frail. In the community dwelling individuals over 65, it's somewhere in the range of 5 to 15%. Similar to fall risk, it's higher in women. It is higher in those diagnosed with cancer. And similar to falls, your risk for frailty increases as you age. So how do we evaluate frailty? So you can look at physical characteristics or symptoms. Like I said, one of those, the eyeball test, just looking at somebody. And there's, Fried's phenotype is kind of the most common way that we go about classifying it based on physical characteristics. And then there's starting to be more and more research done on biomarkers that we can use to assess and predict somebody's frailty levels. So Fried's frailty phenotype, basically it classifies a person as frail as if they have three or more of the following of these. So slow walking speed, impaired grip strength, declining activities, exhaustion, unintended weight loss. The exhaustion one, it's literally they ask a question like, have you stayed in bed all day, several times in the past month? Some of these are just like subjective, and then some they actually measure. And there's like grids on what kind of score they get based. But if you meet three of those, then you're classified as frail. One to two of those, if you're meeting that, then they classify you as pretty frail. Next slide. And there, basically, I don't know if you can zoom in on that. I mean, when you guys get access to the slides, but that's basically like how, what grip is considered weak, what gait speed is considered slow when assessing this using Fried's criteria. We don't need to get into it right now. So the biomarkers associated with frailty, and this is kind of an emerging area right now. They've been doing a lot of research on it. So your inflammatory markers, interleukin-6, your C-reactive peptide, your tumor necrosis factor alpha, all of those tend to be significantly elevated in patients that meet criteria for frailty, meaning they've done like they meet Fried's criteria, so we've already classified them as frail. If you look at these inflammatory markers compared to people that aren't considered to be frail, they're more significantly elevated. There's also the aging biomarkers that people are looking at. So your mitochondrial DNA copy number in frail individuals is going to be decreased. Your telomere length is going to be decreased, and your DNA methylation is going to be increased. And then other biomarkers, your B-natriuretic peptide, which we also look at in terms of people with heart failure, is going to be elevated. Your hemoglobin A1C, which is how we kind of assess diabetic control in diabetics, and your just basically insulin resistance is going to be higher than someone that isn't frail. Albumin, which is kind of a nutrition factor, is going to be lower, right? So that goes along with someone that's more malnutritioned. Yeah, well, malnourished. That's the word I'm looking for. And then fibrinogen, which is part of the clotting cascade, inflammatory cascade as well, is going to be elevated in somebody that's frail. So frailty and mortality. Baseline frailty rates, when you're looking at females compared to non-frail females, have a hazard ratio of about 1.71. So it means they're about 1.7 times more likely to die, essentially, than someone's not frail. It's even more pronounced in males. So similar in falls. So like I told you before, males are less likely to fall, but those that do are more likely to die from a fall. Males are less likely to be frail, but those that are more likely to die from said frailty. Some even studies can report these death rates as high as like 3 to 5 times frail versus non-frail. And then the last little part of the slide again, just repeating the fact that females are more likely to be frail but less likely to die from frailty comparative to males. So here's another Kaplan-Meier curve, just basically illustrating this. This one's looking at frailty degrees, frailty index of men, across time. And the lower the frailty index, the longer they survive, the higher the frailty index. Obviously, the quicker they pass away. And then the same chart, but looking at females. So again, the lower the frailty index, the better they do. The higher the frailty index, the less time they have left. Functional status, the final F. So functional status, it's basically a measure of the overall impact on an individual's health and the concept of his or her environment or social relationships. And they break it down into, there's three that we look at. There's the activities of daily living, or what we call the ADLs. There's the instrumental activities of daily living, what we call the IADLs. And then there's the advanced activities of daily living, which some people report, other people, like, you may not hear a doctor ever say those words. But that's basically AADLs. Essentially, you can think of it as how independently a person can function. Somebody that can do all their own ADLs, IADLs, and advanced activities of daily living can function and live independently, right? They can do their own dressing and toileting. They can go to the store. They can manage their finances. They can plan parties. They can do all of these things. But as you obviously start having trouble with those, we say you start having trouble with IDLs, managing your finances, or your ADLs, managing, taking care of yourself, eating, feeding yourself, or toileting. Then we call that declining functional status. The more assistance you need with these ADLs, IADLs, and AADLs. So here's what essentially the ADLs, IADLs are. So for activities of daily living are the ADLs on the far left. Basically, it's bathing, toileting, dressing, transferring, maintaining continence, and feeding. Right, things that all of us have to do every single day. And if we cannot do one of these things, then we probably cannot live alone, because you're going to need assistance in all of those things. I mean, you have to do all those things on a given day, I guess is the better way to say it. And if you need assistance with one, then you probably cannot live alone. Instrumental activities are more social, right? Like, I need to go grocery shopping to buy my food so I can eat. I need to manage my finances so I have money to buy my food at the grocery store. I need to be able to cook said food or somehow plan my meals on what I'm going to eat. I need to make sure my house is clean. I need to be able to get to and from where I need to go, doctor's appointments, the grocery store, the bank. And, as I said before, you got to manage your money. Typically people, when they start to have functional decline, you see it first in the IADLs before you do in the ADLs, right? Someone's probably, if they're, say, starting to have cognitive changes or becoming demented, you're going to start to see them forgetting to pay bills or manage their money or buy stuff at the grocery store, right? They're going to be surprised that there's just not food in the pantry before that they start having trouble, remembering how to bathe or how to eat or use the restroom. And then finally, the advanced activities, they require the highest level, right? So that's more of like, I've got to plan a graduation party for my niece. So I've got to figure out how many people are coming, what I'm going to feed them, does anybody have any allergies? And so it takes a lot of extra work. And obviously somebody that can do that is, should be functioning fine and not have any issues in the lesser areas of the IADLs or ADLs. If that makes sense. Go to the next slide. So the other thing that's important to think about when you're thinking about somebody's functional status is it can be a harbinger of disease, right? So if I've got somebody that normally, doesn't have any bathroom issues, right? They don't have any incontinence issues, then they're suddenly starting to have incontinence issues. Well, it could be a couple different things medically. One, it could be now they're developing diabetes and they've got a bunch of glucose in their urine and that's making them have to pee constantly and they're not making it to the bathroom on time. Could be a mobility thing. They're just getting weaker and they feel the urge later that they have to go and they can't make it to the bathroom in time. Similarly, somebody that lives in a two-story house and has never had a problem and suddenly is getting really winded just going up their stairs that they've gone up their whole life. Could be they're developing pulmonary disease. Could be that they need a heart catheterization because they're developing coronary artery disease, and that extra work of going up the stairs is starting to make them symptomatic. All those things are possibilities you'd have to look into as a physician if somebody starts to have declining functional status in these areas. And then if they start forgetting doctor's appointments, they start forgetting some of these IDLs, then that's when you would start as a physician looking into doing dementia screenings, things like MMSEs or MOCAs to make sure cognitively they're not, they're where they should be. We all have a little bit of a cognitive decline as we age. We call that natural age-related cognitive decline, but make sure that it's not more pronounced into the mild cognitive impairment range or even into dementia. Yeah, next slide. So how does functional status affect mortality? There's a really famous, well-studied journal of the American Medical Association in '98. Basically looked at 90-day anterior mortality following hospitalizations, and they made like a functional access using your IADLs and then the MMSE we talked about, and a little bit in depression scales as well. And they risk stratified people in low, medium, and high risk groups. Essentially, what it found is, I mean, based on your functional status, if you had a poor functional status before you went into the hospital, you were likely, I mean, obviously you weren't going to come out with a better functional status. You were still going to be poor, but you had a higher mortality um, likelihood than somebody that, had a high functional status going in and came out with a high or say medium functional status. Because obviously functional status can change based on what sent you to the hospital, right? Did you have a head bleed and now you have a neuro deficit? Did you have a hip fracture? Those things can change your functional status. But if you went from say high or normal functioning status to medium, that's going to be better than if you came out with a low functioning status, is essentially what the study illustrated. So, so this, it's kind of interesting. This is looking at functional status and mortality, and then they're also looking at it, comparing it to urea, albumin, and vitamin B12 levels using Kaplan-Meier curves. So the top left chart is by functional status. And so obviously the top one, it's somebody that's independent, and then the middle one is someone that's frail, and then the green line is somebody that's like basically fully dependent for all, like needs a caregiver to do everything. They have fully dependent to eat, toilet, that kind of thing. Obviously, they have the shortest life expectancy. The second chart B, that was looking at urea. So somebody that's got elevated urea, that goes along with it. That's something we use to track renal function along with creatinine. And so somebody with elevated urea may indicate worsening renal function. And so typically they have a higher associated mortality with that. Albumin, if their albumin is low, that goes along with malnourishment. And again, increased rate of mortality. And finally, vitamin B12, similarly, if you've got a low B12 compared to regular B12, then your mortality is greater as well. Next slide. How do we underwrite for functional status? So the majority of reinsurance manuals basically recommend declines if you fail any activity of daily living, or if you need like a little bit of help with more than two. Any of the IADL failures, like I can't go shopping for myself, I can't manage my finances, they're basically recommending to the medical director, and the majority of those are probably going to be declined. So, in conclusion, as you guys can see, frailty, functional status are intertwined. In both those, the more frail you get, the declining functional status you are, and the increased fall risk you have. And a fall in itself can decrease your functional status, as we talked about. If you fall and you hit your head and have a head bleed and now have a neurologic deficit or a hip fracture, all can be that first initial kind of thing that sets you down a declining functional status. All three of these are associated with increased risk of mortality. As I harped on a little bit earlier, exercise, healthy dieting is going to decrease your chance of having medical comorbidities, having frailty, having a fall risk, and hopefully keeps you as functional as you can be as long as you can be. So we'll open it up for some questions. I think I got to click it over here. Let's see. I don't see any questions. Mike, you got any questions?
Sure. One question I had relates to your observation that women tend to be more frail than men. How much does bone density have to do with this? If you were trying to explain why women are more frail than men, what would your uh, reasons be?
Yeah, well, obviously, women have a smaller skeletal frame. Their bones aren't as large and typically tend not to be as dense. They're at higher risk for osteoporosis or bone thinning. And so, if you have smaller bones that are thinner, they're more likely to break, just statistically. So they're more at risk of fracture, but they also can't support the muscle mass, right? And typically, men are better about keeping their muscle mass on as they age, comparative to females. And so, their balance tends to be better, and they tend to have less falls, as we talked about, because of that.
Um, are medications, you talked about exercise, but are medications part of what kind of program you might put together, particularly for a woman with, low bone density.
Yeah, I mean, they women with low bone density and say that they're doing the bone density scans and they're osteoporotic. Yeah, there's the bisphosphonates. You can alendronate's a common one to try to hopefully thicken up some of the bones or at least decrease the decline and bone resorption loss. So there's medications you can use for osteoporosis if that's your question. In terms of medications in general, obviously, I like as a doctor, I want people with a small medication list. Like I want people off blood pressure medication through exercise and diet. I want people that are type 2 diabetics to change their diet and exercise and get healthier so they can come off the metformins of the world. It's typically my stance on that.
And in terms of percentage deaths, you put some statistics out there on deaths, but let's say for an 85-year-old, um, the most common cause of death would be either cancer or cardiovascular.
Right.
I don't recall which is higher at that age, but on the list, on the top 10 list, where would falls rate?
Yeah, falls are going to be lower, right? Like they're more likely to die, as you've elicited, from cardiovascular causes, malignancy, um, stroke, or usually, big three up top, and then infections, right? They're more likely to get septic, and die from an infection than they are probably from a fall. But falls, as I told you, from injury, are the leading cause of death because they can basically start a cascade. You have somebody that's elderly and frail that has that fall and a hip fracture, and now they're in a hospital for weeks on end, and then in a rehab center if they make it out of the hospital, which increases the longer you're in a hospital. Being in a hospital, people don't realize a lot of the time is there's a bunch of risks of other bad things that can happen to you while you're there. So you're at risk of getting, nosocomial infections, which means hospital infections that you wouldn't get out in the community. Things like MRSA, there's specific types of pneumonias. You can get line infections if you've got a central line. You can get ulcers, bed sores. It's not good. And hospital acquired pneumonia, another big one.
Okay, do we have any other questions that have come in?
Not that I've seen, but you can keep firing at me if you want to.
That's okay. I'll put myself to sleep if I do. Um, Thank you so much for your presentation. This is the second of our presentations. As I mentioned earlier, this is a quarterly program. So mark your calendar for about 3 months from now. Also on November 3rd, Monday, November 3rd, we will have our annual longevity conference in Washington, D.C., where we'll cover a number of medical topics and related longevity issues. So let us know if you're interested in that. The continuing education credit just popped up on the screen. You get continuing education credits for this presentation, and just let us know if you have any follow-up questions or suggestions for future webinars. So thank
Yeah,
you again.
we actually
Oh,
got
yeah.
one question. We got one question.
Okay.
Um, Somebody asked if we have any advice on gleaning functional status for older age applicants where medical providers don't capture specific details, basically aside from correlating with comorbidities. Basically, if there's anything, I think what they're asking in when we're reviewing literature, the medical records that can clue us in that they've got a bad functional status if it's not directly addressed. So yeah, you can look at those risk factors that we went over in terms of assessing fall risk. You can look at their medication list. Obviously, the longer that medication list goes, the more comorbidities they're going to have, the increased likelihood of frailty, and likely at some point, whether they have a decreased functional capacity at that point, they're certainly at risk of developing a decreasing functional capacity. A lot of times in the social history part of the application, it'll say they live at home or they live with their husband. And so anybody that lives at home by themselves typically is going to have a better functional capacity, at least if they're doing well by themselves. Obviously, they would. Those would be the areas in the chart that I think I would look if it didn't, wasn't specifically addressed as to what their functional capacity was.
Yeah, we're constrained sometimes by what comes in. I know for older applicants, supplemental questionnaires certainly can be helpful, as indicators of functional status issues. But so often, we're just, as I mentioned, constrained by what we get. Okay.
All right.
Well, thank you again, Scott, and
Happy to do it.
thanks to everyone else. And we will see you in about 3 months.
Sounds good. Take it, Mike. Thanks, everybody.
Okay.